Rajashree madam, sorry. Madam, hello. Rajashree madam.
Yes.
Madam, slide madam cheyo, open cheyano.
Alla onna avidunnu cheyo കാരണം എനിക്ക് ഇവിടുത്തെ ബാൻഡ്വിഡ്ത്ത് കുറഞ്ഞു പോകുമോ ഒരു സംശയമുണ്ട്.
Okay ma'am, share ചെയ്തോളാം.
ഞാൻ നെക്സ്റ്റ് ഒന്ന് പറയാം.
Okay ma'am, I'll do it.
Okay, I'm here too.
Yeah, madam, how do you do this?
Itu ngay luwa umat hindi sa akin.
Writing kayo lah.
Ya, kapag ilan niya.
How to pending so? Ito nga pending na to.
Today is the 4th day of this session in this week, and we have been following with Ramesh and his family closely through his initial symptoms and then symptom control. We learned a bit of things to do and how to talk to Ramesh and his family yesterday. And today we have come to a very crucial part of the palliative care aspect of treating COVID patients, which is end of life. And unfortunately, the way the illness is, people do have a very rapid and a very fast deterioration. So it's a very important session, and I hope you all have had a chance to at least glimpse through the ebook, because it's a great tool to have with you, especially before you attend these sessions. And I will not take much time before I hand over the platform to Dr. Rajashree, who is a very well experienced palliative care physician and has played an active role in writing this ebook and preparing the slides and material for this education sessions. She will be the main facilitator for today. Dr. Roop Gursahani, who's a neurologist at Bombay's Hinduja Hospital, is going to be the co-facilitator, and Moira is around, as I can see her, bright and early in her UK time, and so is Smriti. She has emerged. So hand over the mic, the platform to Dr. Rajashree, and like I said before, please keep the chat box active, and we will love to answer and share all your feeling, thoughts and experiences. Over to you, Dr. Rajashree.
You need to unmute, Dr. Raji, if you can unmute.
Yeah.
Please unmute me.
Okay.
Thank you, Raj madam. Anyway, I had thanked you 3 times for those kind words. Anyway, don't consider me as an expert in this field, because I consider I'm still alive. So when you talk about end of life care, this is a quite difficult, challenging and uncomfortable area, as all of us are aware of. Anyway, let us start the session. Hope you are quite thorough about the algorithm, and with Ramesh's story, we will move ahead. Next slide. So, overview and learning objectives. The present session focuses on understanding death as a natural event. This could be quite difficult for us, because most of consider death as a professional failure. Am I audible?
No, you're audible, ma'am.
Because it's shown on my screen that the host has muted me. That is why I asked.
Okay, now it's okay.
Okay. So, I mean, we have to understand death as a natural event. Then only we will be able to provide the compassionate care. And learning the importance of end-of-life care. Why is it so important? And emphasizing the relevance and challenges with respect to COVID-19. What is so important or specific about COVID-19? and highlighting and mentioning the principles and strategies of providing good end-of-life care for COVID-19 patients. Next slide. So let us be a little bit philosophical. Am I not audible? Dr. Uma Shankari has mentioned that
We cannot see you, Dr. Rajashree.
Ma'am, actually your bandwidth is low. That's why we stopped your video.
Oh,
Because
okay.
Your voice is audible. It's clear.
Okay. So I have to speak somewhere else. You know, like it's difficult. It's my I mean my you know, like picture is, I mean, myself is hidden and only my voice is audible. That's okay. Okay. Death and you know, end of life care is always like that. Little bit of ambiguity and uncertainty in that. So let it you know. Okay. Is it all right now?
Yes, ma'am. Yes, ma'am. All right.
So let us be a bit philosophical. I mean, all the philosophers and great writers and Nobel laureates have defined or explained death in a different way. The Mexican author Don Miguel Angel Ruiz has told that death is not the biggest fear we have. Our biggest fear is taking the risk to be alive, and express what we really are. It's quite confusing. He is a famous author of the book, The Four Agreements of Life. And Octavio Paz, and another Mexican Nobel laureate, has clearly defined that, you know, a civilization that denies death ends by denying life. And Khalil Gibran, who doesn't require any additional introduction, he has seen both life and death together. I mean, you cannot separate death from life. These are closely associated. So that everything shows that death cannot be separated from life, and it has to be seen as something common. Next slide, please. We are moving something more overwhelming. Let us take a break. This is for you to think. Next. Have you ever thought of your own death? That is difficult. Never. What is that stirs your mind when you do so? Are you with me now? Next. What sort of death do you prefer? Slow, instantaneous? It's even more difficult, I think. Next slide. No, next. Where do you like to have it? At home? In the hospital? Or somewhere in serene place? Next. Who do you want to be with you? Your family members, friends, or spiritual leaders? And finally, the last and the most important. Next. Are you bothered about how others die? This is the most important thing. So let us take a break here and go to the chat box.
Dr. Raji, you want me to join in?
Yeah, definitely,
Okay.
definitely.
Yeah. So I've been looking at the chat box, and yes, somebody said that they thought about their own death, kids' future. But at home with family members was then one person, Dr. Sonali said, yes, I want everyone to die gracefully without suffering. So I had asked a question, and that question was, does anyone have any idea of how frequent it is to die suddenly? For example, in persons who cross the age of 50 years, how many are likely to get a sudden death? Painless, smooth, whatever, but sudden. Any ideas, anyone? You can quickly type a figure. I'm giving you 2-3 options.
5 to 10%.
Less than 10%, 10 to 20%, 20 to 30%. Okay, Smriti jumps in with 30%, less than 10%, 20 to 30%. More, 20 to 30%, 30%, 30, 30. Okay, so I think the majority of people have, there was only one correct answer. There's only one paper that has looked at this. I mean, it was a study out of the US, and it's fairly, I think I would agree with it. It's at 7%. So the figure is actually less than 10% after the age of 50 will die suddenly. And it's easy to understand people who die suddenly have risky behaviors and so on, or issues. And most of these are over by the time people cross their 50. So driving motorcycles without helmets, smoking too much, all of that.
Thank you.
Dr. Raji.
Thank you. Thank you. And see, all of us have preferred is, I mean, a painless death without much suffering, want to be preferably at home with our family members. And most of us, I mean, many of us would prefer an instantaneous death, though that doesn't happen so often. As Rup has rightly pointed out, only less than 10% of the people die all on a sudden, and all others will have a slow death. So that is the most important thing, that we should focus on good quality of end of life care. So next slide, please. So why end of life care is important? The sole fact is that almost more than 90% of the people will have a slow death. So providing good end of life care is very important. So where does our country, I mean India, stand? Next. I mean, India's position when 80 countries were studied in 2015 by an agency called Lean Foundation, it was abysmally low as 67 out of 80 countries. It was published in 2015 in Economist Intelligence Unit. Next slide, please. They have taken certain criteria as indicators of quality of death. First, next slide. Palliative, enough. Palliative and healthcare environment is the most important thing. So, general healthcare and palliative care setting accounts for about 20% of the share. So, we have to know that providing good palliative care for a patient who approaches end of life care is very important. And human resources with respect to availability of professionals and access to training is another important criteria which accounts for another 20%. Affordability of care, that is cost effectiveness of the care provided, and the public funding, insurance schemes, everything, that also is important, which accounts for another 20%. And quality of care, which accounts for 30%, spans to monitoring guidelines, opioid availability, and partnership in care. Partnership means partnership between the professionals, patient, and the family members. And community engagement is tremendously important, and it accounts for 10%, which accounts for the volunteer network and public awareness about palliative care. So palliative care is a central point when considering quality of death, as found by the Lean Foundation. Though India's rank is abysmally low as 67 out of 80, Kerala stands out differently because of its unique palliative care providing network, because of the large community engagement and public awareness about the fact of palliative care. Next. So this is a golden statement by Jan Stensvard, with Swedish oncologist and pioneer in developing WHO analgesic ladder. We ought to give those who are to live life the same care and attention that we give to those who enter life, the newborns. We know that is strikingly different. So you can think about the amount of care and the compassion and the love we give to newborns. We have an ICU, we have that kind of care. You know, we take the newborns close to our heart. But when it comes to end of life care and to people, care to the people who are approaching end of life phase, it is almost neglected, as if it is a kind of professional failure. It shouldn't be like that. People who are to exit the world has to be given the same care and attention for just like those who enter the life. Next. So let us see what are the relevances and the challenges of end of life in the context of COVID-19. You may be, quite aware of those facts. Let us see the chat box now. Please post. What are the challenges of end of life care in COVID-19? Unpredictable and sudden. Impersonal given isolation and PPE. Okay. Very good, very good. I think you can contribute more. No family nearby. Exactly, exactly. Place of death. Definitely, we don't have any choice. Lack of loved ones at bedside or ability. Yesterday, Sonali was telling, instead of bedside, we have to move to website. Isolation, hospitalization. Yes, Roop has come with, did I give him the infection? Keep away from family and friends, anxiety, isolation. Last minute talk, it is not possible. Very good. Very good. No matter how good the website manner, the power of touch is lost, and at that crucial moment, yes, absolutely important, madam. Okay. Okay. Next. Acute illness with fast progression. We know that the disease trajectory runs quite fast and many times it is unpredictable. So less time for preparedness. Yesterday, and the day before yesterday, we were discussing in any kind of chronic illness approaching end of life phase, we will be getting some time to interact with the patient and the family member. That is almost completely lost in COVID-19. Next. Limited information, dilemma in decision making, and because still we are not aware of much of the facts regarding COVID-19. So whatever, the professionals also knowing only a part of COVID-19 trajectory till now. So there could be dilemma in decision making. Next. Information overload. Lot of information is showered on you. So there will be high level of anxiety among the family caregivers. Next. Isolation from the family members, which was rightly pointed by many participants, which will make the grieving process much complicated. Yes. Next. Personal protection equipment that hinders effective communication. And, intimidating between you and the patient, and it is quite uncomfortable. You are just cut off from yourself by wearing personal protection equipment. So that is definitely a barrier. Next. Inappropriate artificial life support measures, because there always exists a dilemma in decision making. So unnecessarily we put the patient on artificial life support measures, which may be futile sometimes, which adds to suffering. And you was mentioning about, delirium. Delirium makes the communication extremely difficult. And Spandana was, telling the whole stigma, calling them COVID suspect and COVID positive. That is what, once the patient is diagnosed with a particular disease, there is the name of the patient is automatically, it is just deleted. We will call them MND patient, Parkinson's patient, dementia patient, just like COVID-19 patient. That, kind of, instead of calling the patient by name, we call the patient by, the disease. That is miserable. So everything put together makes end of life care in COVID-19 really difficult and challenging. Next. So this is an important slide where I want to spend some time. Avoiding futile and inappropriate management is very crucial while providing end of life care in COVID-19. This is ICMR has come forward with definition and explanation of terms on 12th March 2018, because there exists a dilemma in withholding and withdrawing a potentially futile life support measures among the professionals. They think that by withdrawing or withholding a life supportive measure, they will be just putting the patient into death, or they will be killing the patient. So it is, considered as a kind of euthanasia. Please understand that euthanasia is totally different from withholding or withdrawing a potentially inappropriate treatment in a patient dying with a terminal illness. Okay. Euthanasia, on the other hand, it is a deliberate intervention carried out by the medical professional with a clear intention to kill the patient with competent request by the patient himself or herself. Okay, so the action is deliberate, the intention is to kill, and there will be a competent request by the patient. I mean, doing some procedure or giving a drug for a patient with some kind of illness or even end of life phase without his consent, he is not euthanasia but murder. On the other hand, withholding or withdrawing a potentially inappropriate treatment is not euthanasia, but you are just avoiding or withholding the suffering of the patient. And the patient may die eventually, but it is not because of the life supportive measures are withdrawn or withheld, but that occurs as a natural death. Having said that, among withholding or withdrawing, there could be some difference. Probably, it could be morally different for some professionals. Probably Roop can contribute to that. Roop, please.
Yeah, yeah. So I have actually put it in the chat box.
Okay.
So if somebody is on the ventilator and then you take it off, or you don't put the ventilator on at all, are both of these the same? Can somebody comment in the chat box? Are they equal or are they not equal? Just yes, no. Yes for equal, no for not equal. No, no, not equal. Yes, equal, not equal, not equal. So, not equal. Okay. So, quick bit of commentary here. Withholding and withdrawing are both morally, legally, ethically equal. So, in both cases, by not doing or withdrawing treatment in some ways, yes, although this was an individual who was nearing the end of life, there is a proximate action which people feel responsible for. But when people have looked at it in an ethical term, they are not seen as different. Both withholding and withdrawing are seen as equal. Yet, when it is us, it is families, withdrawing, which means removing the ventilator after it is put on, is always very much more emotionally difficult. Which is why, if you look at our discussion, and this is the point that we have been trying to come to it, that if this withholding decision is taken carefully well in advance, it actually reduces the trauma for the family. In fact, for the trauma for the team as well. Raji, will you take on?
Yeah, Sonali has commented, compassionate meaning to let the patient be in his or her natural state. She prefers that term rather than withdrawing, which sounds like stepping away.
Allowing natural death.
Yeah, yeah. And withholding can be rephrased as avoiding aggressive measures that will simply prolong the inevitable. I like the term non-escalation compared to withholding. Spandana comes with that statement. Yes, allowing natural death or natural data. Sonali, allowing natural death. Good suggestions. Okay. So anyway, please understand that euthanasia stands entirely different, and whether euthanasia is always voluntary and it is always active. And it is, there is nothing like involuntary, passive euthanasia or non-voluntary, nothing. Euthanasia is always voluntary and it is always active. Next slide. So we will go ahead with it. Ramesh, Ramesh condition has deteriorated further, and it is clear that he deserves good end of life care. The medical team decided to call a video conference, including the whole family, regarding discussion on goals of care. You have gone through that algorithm, and you know what are the steps to be followed. Next. How do we ensure good quality end of life care? Please put your comments on the chat box. How can we ensure good quality of end of life care? Okay. Morphine. Please. Only morphine. How do we ensure good quality of end of life care? Please. It's only morphine.
Somebody actually had mentioned the elements of a good quality of death.
Understanding patient's wishes. Okay.
No, so I think this statement was made by Dr. Himani. I want a peaceful death with minimal or no suffering at home with family and close friends. And I want a chance to talk for last time with my closed ones.
Yes, very good, very good. Oh, I missed that. Okay, very good, very good, very good.
So can we do that for Ramesh?
Yeah, suitable environment, music, photos, pain control generously, attention to details, very good. Position, Vaseline for lips, spiritual support and symptom control. Okay. And, through video conferencing, Ramesh can see his family members. Very good, if possible. Okay, next. This is the end of life care algorithm given in your toolkit. It is there on page 32, so I am not going to the details. Next. So let us have a plan for end of life care. Next. So we have goals of care discussion with the family members, and as to how to move further, how to provide symptom control, and the last wishes or whatever, the goals of care discussion should be appropriately carried out. And there is a transition from intensive care to palliative care approach with respect to symptom management, medicine, and modes of medicine administration. Next. And consistent involvement of palliative care, not that one consultation is enough. A regular periodic review of the palliative care team and appropriate alterations in the with respect to the symptom control is important. Next. And psychosocial support to the family, followed by bereavement care. Okay, so this is the end of life care plan in nutshell. Next slide, please. So what are the principles of end of life care? Let us have a quick look. Next. Ensure patients' comfort through appropriate symptom control. This should be, people have commented on the chat box that it should be made through appropriate symptom control. How can we ensure appropriate symptom control? This is by refocusing medical and nursing care. So how can we do that? Instead of taking the routine vital sign recording or intake output chart and frequent turning regimes, which could be quite disturbing for the patient, we can have a symptom-based approach and a compassionate care. And avoiding unnecessary intervention like central venous cannulation and artificial feeding, and reviewing all medicines and symptoms regularly, because the symptoms during end of life phase may change quite often, and it requires periodic assessment and review and change of medicines and routes of administration regularly. Next. And we have to maintain effective communication. We saw how important is effective communication in the previous class. Next. And offering or providing continuous psychosocial support to the family members. And let us see the chat box now. what is the end of life period and how to decide?
Right. So, did anybody mention that? That was one question. The other question, the other
Biju has come forward with a statement how to ensure good end of life care, physical comfort, peace of mind for both patient and family, dignity of life where wishes fulfilled. Because two has, commented what was the end of life, the wishes Ramesh had expressed. Did we have a checklist? Whether we have asked him about that. That is the importance of maintaining effective communication with the patient. Just because he was receiving high flow oxygen therapy or life-saving measures, that doesn't mean that the communication should be stopped. And psychological support.
So there's also the question of DNAR. Shilpa has asked for that.
Okay, Roop, would you like to comment on that before going to the next slide?
Yeah,
Okay.
yeah. So if you look at it, CPR in somebody who has COVID is in any case difficult, because if you're doing CPR, you're going to release a lot of aerosols. And in any case, these are patients, especially for Ramesh, where you have, as it is decided that you're going to allow natural death, then you are actually going to torture Ramesh by doing CPR on him. So DNAR, the fact that you do not attempt resuscitation is a medical requirement for Ramesh. And since this has been discussed with his family, and maybe even Ramesh has probably at some time in the past expressed his wishes, it is appropriate. Now, the question is, for a long time, Indian doctors were very confused. Is it legal? Is it not legal? The Supreme Court gave us the right to autonomy and said that we can make these choices. But more importantly, the ICMR actually put out the way it has to be done. So it has an algorithm, some part of which overlaps with what you're seeing here. And it also put out a recommended form. So if any of you downloads that, I will try and put the link in the chat box a little later. If any of you wants it, you just have to print that form out, and that has to be signed by the surrogate. Obviously, Ramesh is in no condition to sign it, and the treating doctor. And you will see the details on the DNA form. It's effectively the standard of care for Indian doctors now. If the patient has not expressed a wish for DNAR, yes, but at this time Ramesh is delirious, and it's quite unlikely that we can communicate well with him. So his surrogates will make this decision. His surrogates will be first, ideally his spouse, but then adult children. Typically in a Indian family, it would be everybody making a joint decision. Dr. Raji.
Thank you, Roop. Thank you. We may share the link to that article, no?
Yeah, I will.
Yes. Next slide, please. So, strategies for effective end of life care. We have said, it is appropriate symptom management and maintaining effective communication and providing psychosocial support to the patient and the family members. So, come to the symptom management first. The troublesome symptoms towards end of life phase are breathlessness, agitation, pain, fever, secretions, and pressure injury. Even pressure applied to a body surface, particularly over bony prominence, for more than 30 minutes continuously, is likely to injure or hinder with the vascular supply to that area and may lead to pressure injury. And so appropriate personal protection equipment should be used while managing the symptoms. Next slide, please. So you have seen in the previous session of symptom management how breathlessness can be effectively managed, from mild breathlessness through moderate and to refractory breathlessness. The algorithm which is meant for refractory breathlessness stands good here also. So we can give injection morphine 5 milligrams subcutaneously or 2.5 milligram intravenously, or injection fentanyl 50 microgram and injection midazolam 5 milligram subcutaneously or 2.5 milligram intravenously may be given as a bolus and may be repeated every 15 to 30 minutes till the symptoms improve. Or then start continuous infusion if indicated of injection morphine 30 milligram or injection fentanyl. It is according to the institution preference. Fentanyl 150 to 300 microgram and injection midazolam 15 milligram to 60 milligram subcutaneously or intravenously over 24 hours as continuous subcutaneous infusion if possible. Having said that, so morphine infusion is comparatively much cheaper compared to injection fentanyl. But still, if your institution has got injection fentanyl, and if you are more comfortable in using injection fentanyl, there is no problem in that. Only thing is that that's a costly affair. And how to give subcutaneous injection? It is very well given on the end of life care, like chapters on the toolkit from page 36, I believe, 36 or 37. There are certain sites where subcutaneous injection can be comfortably given. Okay, and it is a comfortable route both for the patient and the family members, and even for the ward sisters as well if they are adequately trained in that, because it is less painful and there will be less chance for additional infection, which an intravenous cannulation might predispose to. Next slide, please. Let us move on to agitation. We have we know that in agitation towards end of life phase, it will be with disorientation as well. So we have to combine an antipsychotic, which is a dopamine antagonist. That is, our preferred antipsychotic is injection haloperidol because it is cheaper and most time tested, and 20 milligram, and injection midazolam 30 milligram as a continuous infusion, either intravenous or preferably subcutaneous over 24 hours. That is the most accepted, combination which may be used for managing agitation with disorientation. It was usually useful, but in COVID-19, the agitation can be horrendous and may not easily respond. In non-COVID patient, usually patients respond to haloperidol midazolam combination during the end of life phase. Next slide, please. So we come to pain and fever management. Paracetamol is a preferred drug. So when we give paracetamol, give the appropriate dose at the regular intervals. 500 milligram to 1 gram 6 hourly is the recommended dose for paracetamol for pain management. It may go up to 4 gram over 24 hours, either as IV infusion. Oral administration could be difficult in an agitated patient, particularly towards end of life phase, or it may be given as a suppository. It is quite good in controlling fever and as well as pain. NSAID also may be used, but we have to be aware of the altered renal function and the side effects of the NSAID when it is given in a more vulnerable patient. If a patient is already on opioids, continue according to the response. Having said that, I would emphasize pain assessment could be difficult as response will be either sluggish or absent as the patient approaches end of life phase. So we have to go by, the symptom assessment, whether he is comfortable or whether he is not groaning. Particularly when the position is changed, we have to go by that, science. Exact pain scale response we will not be able to assess. So any condition, when you administer any drug like opioids or NSAID, beware of the altered renal function. So the doses may require necessary adjustment. Next slide. So we come to another symptom which haven't touched so far, secretion. So usually in any ICU, suction is the preferred method to control secretion. So in COVID-19 patient, whether in ICU or ward, suction is best avoided because of the propensity to produce aerosol generation and disease contamination. So simple position change to facilitate the drainage of collected secretion would be sufficient. And if the secretions are troublesome, antisyllagogues may be used, and glycopyrrolate, if available, is a potent antisyllagogue, 200 microgram to 400 microgram, that is 0.2 milligram to 0.4 milligram, 4 hourly, either given intravenously or subcutaneously, will do the purpose. Or you can give hyoscine butyl bromide, that is Buscopan, 20 to 40 milligram 4 hourly, either intravenously or subcutaneously. Subcutaneous is the best route. Having said that, I would like to reiterate, hyoscine butyl bromide is practically useless drug when it is given orally, because the oral bioavailability is less than 20%. If you don't have anything else, atropine 1% ophthalmic solution is quite good. 1 to 2 drops 4 hourly may be given sublingually. Next please. So when we use anti-sialagogue, please understand that too thick, they will make the secretions thick, and too thick secretion will add to symptom burden. Patient will not be in a position to communicate to you that I have some discomfort in my throat or mouth, but it could be quite disturbing for the patient. And xerostomia is uncomfortable for the patient, and it might facilitate fungal colonization. The normal, like the biological environment in our oral cavity is quite, it is necessary for pathogenic, to avoid or wipe away the pathogenic organism growth. But when our mouth gets dried up too much, it will add, facilitate fungal colonization and add to symptom burden. Next slide, please. So pressure injury, we have said that even 30 minutes pressure to a vulnerable area may predispose to pressure injury. And the first stage, I would call it like pressure injury rather than pressure ulcer, because in the first stage of pressure ulcer, the ulcer is not present. It is only the injury which is present. You can see only the non-blanchable erythema. So this will be easily overlooked. And we will just check the routine pressure point areas, which is given on the nursing care page. But we may miss the silent pressure points, which are produced by the endotracheal tubes, nasogastric tube, and the mask, like of the nasal cartilage, and on the face, endotracheal tube to the angle of mouth, and the nasogastric tube to the nasal cartilage. And these points should be especially looked for. And we have seen even in the non-COVID patient these devices cause pressure injury. Pressure reducing mattress, it offers some help, but these are not substitute for gentle turning regimes and for skin care. Okay, and often we have a misunderstanding that if you just give pressure reducing mattress, that will take care of everything. It is not. It is not. We have seen patients coming from ICU with lot of pressure injury. So pressure reducing mattress, it will just help you to prevent pressure ulcer, but that will just, it is not a substitute anywhere. How can we provide skincare? By avoiding soiling with urine and fecal matter, and like talcum powders should be totally avoided. And instead of that, you can apply moisturizers like Vaseline and gentle massaging of pressure points after taking adequate protection, particularly with respect to COVID-19 care. That may be done. And 2 rigid turning regimes, because we know that for a supine patient who is bedbound, we have to have 2 hourly turning regime. For a patient who is seated, we have to have 1 hour turning regime. These, anyway, this patient is not going to be seated. 2 hourly rigid turning regimes may be avoided. It may be adapted to patient comfort. Next slide, please. So, we have seen how effectively we can give end-of-life care to Ramesh. Now the question is that, after discussion with the treating team regarding goals of care, because Ramesh had expressed a wish long ago before catching coronavirus infection, that I don't want to die in a hospital, I prefer to be at home. So because he had expressed such a wish, the family told the treating team that they would like to take him home for end-of-life care. So now we have challenging questions. Next. What is the government directive about care of COVID-19 positive patients at home? Is it that easy, just like any other patient being taken home? Next. Even if allowed, how can care be given at home? That is another challenge. Because it is a It's a highly infectious disease. Next. How will their neighbors react? Okay, you have decided, in the treating team has agreed. What about the neighbors? They are just living next door. What chat box says.
It says that there was only one from Shilpa Khanna who said, okay to take home, and we support an EOLC. Normally, yes, that is what we would do, but not with COVID. It's not. It's going to be too much of a challenge.
Yeah, Roop, because it is like, though we just want to respect the patient autonomy and the patient's wishes. COVID-19 is a difficult, tricky, and challenging scenario. As of now, at least in Kerala, there is no provision for the patient to be taken home. As of now,
No way.
it is not possible because of the disease contagion and the protocols prevailing in the society, and the government directive does not allow the patient to be taken home for the management of end-of-life care. That is the situation at present in India now. I don't know whether if there is a massive community outbreak, and if the hospitals get saturated, I'm not sure whether we have to face such a challenging
Situation.
challenging situation. So what all things we should
Does anybody know, has this happened anywhere? Anybody has any idea where did this happen? What the situation that Dr. Raji just spoke about?
Yeah, Moira has commented, I think there is a possible change for home care coming in many low middle income countries. There could be. That is something.
Yeah, I think there is a lot of it. It is routine in higher income countries at the moment, and I think it is also coming in lower income settings. But I think there's two issues. One is what will happen if they go home, but also how do you handle the request to take them home? I think those are the two issues, aren't they?
That's very important. That is,
because somebody has asked, that means do we say no to his wish, and why can't we keep the patient, the caregiver, completely isolated? So I think the main worry is how to deal with this request.
Yeah, that's a possibility. And you can do something like a reverse quarantine. Only the patient and the caregiver can be isolated, and the rest of the people may be shifted to some other. Even then, caregiver carries a high amount of risk.
I think the important thing is whatever the policy is, because this COVID is governed by your local policies. So we will have to follow those local policies.
Exactly.
And at the same time, I think we just need to maintain that basic principle of communication as to accept, acknowledge their concern, their worry, and then be very assertive that it's not possible, unfortunately, because it is COVID. Empathetic, listen to them, sympathize. It is a hard thing. It is very, very difficult. God forbid it shouldn't happen, but it is happening, and it is here for truth. And therefore, we are here to support each other.
Exactly, madam. You said it right, because we have to acknowledge, the agony and the frustration among the family members, because they can't see him, he can't see them. They will not be able to provide the whatever the last rites, towards end of life and the dying hours. And even in some places, even the family members won't be allowed to see the body as well, and the protocols regarding burial and cremation, everything is quite hard to accept. But we have to be assertive at certain times. We have, when it comes to personal wish and society wish, you have to give more value for the society wish according to the protocols and the prevailing regulations. Okay, so shall we move on to the next slide? So let us see what are the challenges at home or community setting. Shall we see the chat box then? So suppose there is a situation where Ramesh is allowed to taken home. So what are the challenges?
Who will certify death? Will a doctor come home to certify death?
Yeah, that is something. Okay. Who will certify death then? Will a doctor come home to certify death? What else?
How about when the body has to be packed up? How will you manage that?
Okay.
maintaining infection control.
How will the burial be? Maintaining, obeying the infection control protocol.
Yeah, because the body has to be wrapped in plastic and all those regulations are fairly clear. So you will have to have people coming in with hazmat suits with all the packaging to do it all at home.
And come on, you are in the hospital. We are all equipped with PPE. And the poor family member, is he or she aware of how to, about donning and doffing of PPE? How to teach them? And we are so proficient in giving intravenous or subcutaneous lines. Do they know that? So how they give medicines there? Anyway, for symptom control, we have to give some kind of medicine by some route.
Otherwise, he will have a fairly distressful death at home.
Yeah, distressful. Exactly. So let us see one by one. Next. Lack of knowledge and expertise in managing a highly infectious disease. This is a very challenging situation. It's not only caring the patient, disinfection. Suppose if the patient pass motion or pass urine or even he spits out sputum, how to dispose it properly, avoiding spillage, disposal of waste and following protocols. The family member, even society may not be knowing all those things. Next. Lack of professional support, as it was shown in the chat post. Does a doctor or nurse visit home frequently to guide us how to provide care at home? Next. Inexperience in using medicines and medical gadgets. You know how to give morphine. You know the side effect of morphine. You know how to give haloperidol. What are the side effects? We don't know anything. We haven't used it. And the medical gadgets, how to place a needle, how to put the suppository. It is quite easy for me to tell. You can apply paracetamol suppository. It works well. Is it comfortable for them to put something in the anal canal or in the rectum? Do we check that? Next slide, please. Next, please. Inadequate supply of medicines. Even the COVID hospital sometimes run short of medicines and PPE. So how can we ensure the adequate supply of medicines and PPE to the home care setting? Next. Emotional distress. Why should, I have to take him home. If he had been in the hospital, he would have been managed better. And I had taken him home. So now I have, brought a possibility of, brought him home. So there is every possibility of disease getting transmitted to other people. So I am guilty of that. I am quite anxious about that. This is, this emotional distress is quite often, it's not seen so often. It is always buried. This is a very challenging thing. Next. Isolation due to quarantine. And once you bring the patient, you are cut off. You are cut off from the society. You are cut off from the rest of the family members. All other family members have to shift to other place. So you are totally isolated. So these are the challenges when such a disease or such a patient has to be managed at home or in the community setting. Next. And stigma from the society. It is profound. And we will see that in addressing the distress tomorrow. Making sense of distress during COVID-19, it is terrible and it is horrendous. Even it is quite prevalent even in the educated group of people. Unnecessary fears and stigma against patient and their family members. Next slide, please. And what are the strategies? Let us have a look. Next, appropriate training of the family member. Suppose if we come across with such a situation, appropriate training of the family member for using medicines and gadgets. Rectal application and subcutaneous medication can be appropriately trained, probably with the help of some mannequin or dummy or something like that, and ensure adequate supply of medicines and gadgets and routes of administration, subcutaneous, buccal and sublingual, rectal, topical application. Suppose if fentanyl patches are available, that also can be taught them very clearly, and clear written instruction should be given to the family members. Whatever you talk of, it will just got, evaporated. Just give clear written instructions in the local language which they can follow. And disinfection. For simple disinfection, 1% bleaching solution can be used for household articles. This is made by dissolving dissolving 30 gram of household bleach in 1 liter of clean water. 30 gram of household bleach can be made into a paste, and it can be added to 1 liter of clean water. And after some time, 10 or 15 minutes, that supernatant solution you can use. That will give you 1% bleaching solution. That can be kept clean or that can be used for 24 hours for household purpose. In the healthcare setting, it may have to be changed 6 hourly or 8 hourly. In a household setting, it may be used for 24 hours. Appropriate disposal of waste material, we have to put it in a pit and appropriately cover it, or you have to flush off the excreta, and we should avoid spillage of the waste materials here and there. And self-care, personal protection equipment. And it's not only that we have to give them, we have to train them also how to use it properly, along with routine mask and social distancing and hand hygiene. Everything should be taught properly and address the emotional burden. And I understand that it is not viable in Indian context, because I just emphasized it, because anything we have to see how it can be managed in the home care setting as well. Right now, COVID-19 patients are managed only in the hospital in India. I know that. Next, please. Counseling and regular support by phone calls and WhatsApp chats. And we have to give regular updating with latest guidelines and protocols regarding death, burial and cremation guidelines. And there is always a provision for liaising with local healthcare authorities, because the protocols may change and the local healthcare authorities can give necessary help and support for updating with the protocols. This is always helpful because they are available at hand. Next slide, please. So effective communication, we have gone through that. The challenges are high emotional distress pertaining to COVID-19, and we have discussed the barriers to communication as well. And what are the strategies? Next. Maintaining, exploring concerns. Always keep asking, do you want to learn more, or do you want to know anything more? So keep asking questions and explore concerns, and active listening always, and information sharing. When you share information, it has to be clear, and you have to be honest while you give the information, and you shouldn't overload them with too much of information, and it should be in local language which they cannot follow. And acknowledging reaction. Don't take anything personally. If they cry, or if they get angry at you, it is not because they are against you or somebody else. They have just found you as a pillar to lean on, and you have found you as a person where they can shower their reactions, or they can ventilate their emotions. So just acknowledge reactions as it is. Don't take anything personally, and express empathy at all steps. Next slide, please. Family support. The grieving process could be complicated because the family is separated from the patient quite early. So, and it is quite unexpected as well. So anticipatory grief may complicate the grieving process. So there could be quarantine issues and the stigma from the society. So regular support by means of telephonic, WhatsApp chat and video call wherever and whenever possible. Next slide, please. So there is a question in the chat box. What if an elderly with comorbidities with mild to moderate COVID-19 infection being managed at home? Joint decision by patient and family to not escalate care even if needed. So if he deteriorates, family still has to take him to hospital to die and for burial procedure. So see, by principle wise, he is elderly person with moderate comorbidities, unlikely to survive the the challenge or the threat of COVID-19 infection, because he may succumb easily. But age alone is not a criteria. It is comorbidities which matter a lot. But if as of now, a COVID-19 infection in India cannot be treated at home. He has to be taken to hospital. So anyone else can contribute further?
So as of now, since it's a notifiable disease, the BMC has to be informed. For example, I appreciate your concern that the patient is at home and the family decides not to take him, but you still need somebody to verify, you need somebody to certify, you need a doctor. That doctor will notify the BMC. Plus, you need somebody to come home to give you treatment in terms of for his breathlessness, for his fever. The minute you contact a doctor, that doctor is going to notify the BMC and the corporation or the municipal authorities, and they are going to take that patient away. At this moment, there is no, because it's a notifiable disease, because it's not just the person concerned or the family, but it's the large population at risk. And you will need
Exactly,
a doctor.
exactly.
You will need a doctor to treat because the whole focus is on comfort of the patient, even if not care or cure, you need to keep the patient comfortable. The minute you involve
exactly.
a doctor, it is going to be something that the corporation or the authorities will take note of it and will take the patient to hospital. So it's better to have a transparent process than hide and do this kind of thing, because that is dangerous, considering it's a notifiable disease and it's a communicable disease, and we as doctors should be responsible for the population at large. It's our social moral responsibility.
It is a society's wish and well-being is most important when it comes to personal wish against the society wish.
Sorry, Rup, you were saying something.
Yeah,
no.
So I'll put a question in the chat. I'll put the question in chat.
Moira, please. Moira wants to make a comment.
So I think this is a very interesting conversation. I just think we should separate two things. We must be in keeping with whatever the systems are in our setting. And remember, there's not just people from India coming on to these calls. So different countries will do different things at different times.
Yes, exactly.
So the important thing is to do whatever is in the setting and keep it transparent.
Exactly.
It is perfectly possible. COVID-19, people are at home already before they're diagnosed. And we are also managing it in the community. So there are ways to do it safely, but if your setting is not doing it yet, no problem. It's actually easier to manage a COVID death than it is, for example, an Ebola death, which many of us have been doing in other countries. So the important thing is not to get so wrapped up, I think, in this, but to say, if a person is saying, I want them to come home, what are they really wanting from that? Let's not go into the process too much. The process is the process. But the feelings, the emotions, how we can enable a good death, even without going home, are, I think, the ones we can really tease out. And we have on the other side, and we must use the process. Can I say that is actually quite straightforward to do a COVID death at home if your systems and processes support that. And if they don't, let's not focus on that, but focus on how can we make it a good death, even though they can't go home. Is that okay?
Thank you, Moira.
Excellent. Yeah.
Thank you.
And like Moira said, mild and moderate cases are encouraged to stay at settings where they can quarantine themselves. It is the problem is when there are 10 by 10 with 20 people in it, then even that quarantine becomes difficult in our country.
Fine.
So it's very different. Yes. But like Moira said, we need to think of why this home death is so important and address those values and beliefs and concerns.
Okay. So let us come to the ethics of end-of-life care. Which kind of death would you prefer? Next. This one. Next. The picture gives the answer. I don't have to elaborate. And I can't recall the publication, but in a survey, most of the health professionals prefer to die at home, and even the critical care specialists, they don't want their death to be in ICU. They prefer home.
Not in their own ICU, at least.
Exactly. Next slide, please. So final hours. Next. Properly managed. Next. Family members and caregivers feel confident. There will be a sense of final gift giving. That's a good death. A sense of growth in all the members of the caring team. Next. If it is improperly managed, next. Patient ends up in needless suffering, and the family members live with frustration, worry, and guilt. Opportunity for growth is lost for whole caring team. When death is inevitable, Make it a memorable one. Next slide, please. So finally, accepting death as it comes is the most comforting thing. As Kubler-Ross model of grief has shown, acceptance is the most comforting thing. Next, we haven't come to a full stop. So clinical narrative continues. Ramesh has died and his family have expressed their thanks that he was not alone and did not suffer for long because they have brought him home. They found the opportunity to speak and see him over the phone, so helpful. You are doing a home visit face to face or by telephone to offer support. You find the family particularly distressed as they could not carry out the prayers or funeral rites. And they say, our neighbors don't even greet us anymore and we have lost the heart out of family. How will we ever be at peace? Next. How will you respond? We will take the next slide as well. Next slide. And lockdown is now easing and the numbers of people affected by the virus is increasing. However, everywhere you look, there are people who have been impacted financially across the world. You read stories of migrants who struggle to get home or business going to the wall, of people who could not get the health care, beds not available or cost of the treatment. Because of that, they need it. You see anger and resentment, but also have witnessed many acts of compassion and kindness. Next. You ask yourself, how can I make sense of all these things? Let us take a quick chat box review. How do we make sense of this? And how are we going to respond to the family's cry that our neighbors are not at all greeting us, may they just turn up their faces? How is it going to affect them? Not to feel guilty is it's a difficult thing. It's a challenging thing. Any more comments? A global crisis instills irrational fears in minds of many. Will you say anything specific or just listen to them? Rube is asking. Let the participants come in. Talk to them frequently. Okay. What are they going through?
I think we might have lost Dr. Raji. Dr. Roop, or
Okay.
do you want to come
No,
in?
I'm here. I'm yeah. So one of the things that when this kind of a distress is happening, probably I think the most important thing is just to hear them out. They need somebody to. You may not even have to say anything very definite. The mere fact that you are present and that you are listening, and that you are not judging anything, that's also important. Moira, do you want to add?
I think
Smriti?
Dr. Raji is also back, but I would very much agree. The listening is so important and the empathizing, but I think also finding those acts of kindness and finding ways to look for meaning in the midst of difficulty. but you only do that once you've listened. And then you might say to people, how do you make sense of it? And find out if they're going to give you some ways in which they're helping to make sense of it, and you acknowledge that and build on that. Dr.
Thank you.
Yeah.
Next slide, please. So the Ramesh's son is going through a grieving process. Let us see what are the issues he's facing. Next. He may have physical issues like loss of sleep, fatigue, and poor appetite. Could be physical issues. Next, he could have emotional issues as well, anger, guilt, sadness, and despair. Next, he will have cognitive problems as well, lack of concentration, inattention, and getting connected to the lost or the loved one. And the social issues too, isolation, and the stigma from the society and the problems associated with that, and the spiritual issues as well. Why should it happen to me? What is the meaning of all these things? So next, grief is a total human experience. It just encompasses the whole of human. Never compartmentalize it. It is like physical or psychological. It is a normal process. It can happen to any person, and reassure that it is quite normal for you to experience this kind of feeling. Stand with him, help him to find a way to cope with the situation, not to find a solution for him. Just help him to find a solution. So this is a normal experience, and offer continuing support. Next slide, please. And bereavement in the pandemic is more complicated. Bereavement is a process by which you grieve. It is a period through which you experience the loss. It is more complicated due to the changes in the traditional societal mourning process. Everything is cut off, and the funerals, burials, and gatherings will be governed by strict guidelines and by the local authority. And it cannot happen according to the the religious customs or the family wishes. Not, everything is lost. So it could be quite complicated, and this should be addressed properly. So next slide, please. So take home messages. We will wrap up quickly. So focusing comfort of the patient towards end of life phase, appropriate treatment by avoiding the futile ones, and effective communication, which should be maintained at all levels, and support of the family during end of life phase and bereavement process. So thank you very much. Next slide, please. These are the resources, the additional resources for the end of life care, and the standalone resources for the toolkit. Next. Yes, thank you very much. And I am sorry for the brief period of the lost feeling. I too had that lost feeling when the connectivity got lost. Okay, thank you very much.
Right. So, yes, please fill in your feedback.
Thank you, Mona.
Yeah.
You were my mentors, and the facilitators were with me all the time. Thanks. Thank you for the support.